Welcome to Parallax by Ankur Kalra, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, Interventional Cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello, this is Ankur Kalra, and I am a member of the staff at the Department of Cardiovascular Medicine at the Heart and Vascular Institute at Cleveland Clinic in Cleveland, Ohio. I'm an interventional cardiologist with a focus on coronary and structural heart interventions. I'm also an assistant professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University, also in Cleveland, Ohio. As editor-in-chief of US Cardiology Review, it is my absolute honor and privilege to broadcast Radcliffe Cardiology's first ever podcast series. In 2019, how we imbibe and learn new information has changed. In a profession where information and knowledge are in a constant quote-unquote flow state, precise knowledge can make a difference in someone's life. I've learned from my father that if the mind does not know, the eyes do not see. As our lives keep getting busier and entangled, finding the time and the space to dedicate to reading evolving literature are hard to find. I personally have utilized commuting time and time exercising to cohabitate with learning time. And in the age of information overload, where knowledge is dispensed in different forms of media, it can be daunting to devote 60-odd minutes a day in gathering, reading, and digesting relevant information for professional development and keeping oneself up to date. One of my mentors and now a colleague and dear friend, Duane Pinto, Associate Professor of Medicine at Harvard Medical School, told me as he handed over the Interventional Cardiology graduation certificate, just don't be a technician, be a content expert. I thought through this all as I was putting these series together. We at Radcliffe Cardiology aspire these series to be just the right dose of new knowledge and information you need per podcast. US Cardiology Review publishes contemporary reviews on evolving and topical areas in cardiovascular medicine, encompassing all subspecialties within the field: general cardiology, interventional cardiology, electrophysiology, and advanced heart failure and cardiac transplantation. We've also introduced a new section on preventive cardiology and cardiometabolic disorders after I assumed the role of the editor-in-chief of the journal this past year. The podcast series will be the audio format extension of these seminal reviews. Our goal is to deliver the information you need to know at the patient's bedside in a digestible, conversational audio format. Ladies and gentlemen, I'm thrilled to unveil Radcliffe Group's first podcast series, Parallax. The first podcast discusses the topic of conduction abnormalities after transcatheter aortic valve replacement. This excellent review, which is out now in the spring 2019 issue of the journal, has been authored by physicians from the Lenox Hill Hospital in New York. For our first podcast feature, I had the privilege to speak with the senior author of this review article, Dr. Chad Kliger, director of the Valve and Structural Heart Center at Lenox Hill Heart and Lung in New York. Take a listen to our conversation. I have with me Dr. Chad Kliger. Dr. Kliger is Director of Structural Heart Disease Interventions at Lenox Hill Hospital in New York. And he's joining us here for the first podcast for US Cardiology Review. Welcome, Chad. It's great to have you here.
Thank you, Ankur. Thank you for having me. I think this is a unique way to discuss some of the very important topics that we're showing off in the journal that you're leading, and I think it's a good conversational piece to have. So thank you for having me.
Great. No, I'm glad that you joined us here for the podcast. So thank you again for contributing to US Cardiology Review and for a very important topic that you've written on, which is conduction abnormalities after transcatheter aortic valve replacement. And as we were talking offline, transcatheter aortic valve replacement has grown exponentially over the past 5 years. And I think its applicability to more patients continues to grow. So I think this article is very relevant for the practicing clinician, the practicing cardiologist, as well as interventionalists and electrophysiologists who are taking care of these patients. I want to start off by asking you about conduction abnormalities that you commonly encounter following transcatheter aortic valve replacement. So, what are some of the most common conduction abnormalities you see? And there's a second part to the question is, before you are subjecting a patient to this procedure, are there any baseline electrocardiographic variables that you key into that would prepare you upfront for a conduction abnormality that would occur following transcatheter aortic valve replacement?
Sure. So I think just to start off, I think this is, as we evolve in the TAVR space, I mean, there've been a lot of issues that we've dealt with implantation of valves through the years, and the generation of devices have gotten better and better. I think this next era of TAVR, we're really going to hone in and try to perfect how we manage patients perioperative. And I think one huge aspect of this is intraprocedural, peri-procedural management, even post-procedural management of conduction issues around TAVR implantation. So I think this is a very important topic. I think little guidance that we've had in the past, and I think moving forward, we're going to see a lot more data and treatment algorithms to better help understand what the mechanism is, what happens to these patients with conduction abnormalities, and how we best treat them in a very algorithmic fashion. So the question that you asked, are there features of the electrical system that we look at baseline that sort of will make us a little bit more concerned about TAVR and risk of conduction issues after? And there are. So a baseline right bundle branch block is probably the highest or largest concern for patients entering into the TAVR space, for risk of developing high degree AV block, complete heart block, peri-procedure. So these are the patients that we're clearly most concerned about, and many of our patients will see the electrophysiologist prior to implantation to make sure they don't have any indications for pacemaker prior to TAVR. Other less impactful EKG concerns are your left bundle branch blocks, your hemi blocks, prolonged or long first degree AV blocks at baseline, baseline AFib or baseline bradycardia, or some of the other electrical EKG risk factors that may increase your risk. And it varies between studies, but things that we look at when we see these patients preoperatively.
That's insightful. Thanks for sharing that with us, Chad. What are some of the mechanisms for developing, high-grade AV block or complete AV block, either intra-procedure or immediately following a procedure like transcatheter aortic valve replacement? And I know that surgeons, on the other hand, have dealt with this for a while. Obviously, surgical aortic valve replacement has been around for decades. So if you can dive a little bit into, some of the mechanisms and some of the differences you would see between the two procedures when you compare transcatheter versus surgical aortic valve replacement, some of the pacemaker, or I shouldn't say the pacemaker, but some of the conduction abnormality rates and their difference between the two procedures.
So for surgery, and surgeons have seen post-operative left bundle and high degree AV block for many years. For the surgeons, they do surgical dissection of the valve, decalcification of the native valve before valve implantation. And just from local trauma swelling at the site, you can see changes in that conduction system right where that right and non-coronary cusp is, that can lend itself to trauma to that His-Purkinje AV nodal tissue area. So, and even mechanical compression when they implant these valves, now typically their mode of implantation is really not deep into the LVOT. It's either annular or supraannular, so the compression is less of an issue, but still a possibility when they may try to oversize the valve to get better EOAs and larger valve sizes for their patients. So the surgeons have seen conduction abnormalities for a long time and have seen a need for pacemaker, but the pacemaker rates vary, and bundle branch block rates vary in the surgical population, but you see it really in the single digit levels. For TAVR, sort of that changes a little bit because we don't do resection of that native leaflet. We don't do decalcification of the aortic root. So, things that we think about, like calcification at the areas of that right non-coronary cusp, implanting an intraannular, or even a little slightly deeper into the LVT valve, whether it's a balloon expandable or self-expandable valve, can hit that AV node right where that triangle of Koch is, and put a little pressure where the membranous septum is and where the exit of the left bundle through that base of the membranous septum to really give you a risk for a left bundle branch block or high degree AV block. Now, I think what's interesting is that this is the mechanism, what we see for our transcatheter heart valves, the rates of left bundle branch block, and it varies between the type of prosthesis, but could be as high as 35 to 65% for a left bundle, and with pacemakers rates, as we know, in the anywhere from the 10 to 25% range, also varying between transcatheter prosthesis. Many of these left bundle branch blocks resolve within the first 48 to 72 hours. Many, about half of them do. But we're still left with either subsequent left bundle branch block, conduction issues, or some advancement into high degree AV block that require permanent pacemaker.
That's a great summary, Chad. And I think it's a good segue into the next question that I was going to ask you, which was, how do you manage in your daily practice patients with new onset left bundle branch block following a transcatheter aortic valve replacement, or, for example, a patient with a baseline right bundle branch block who then has temporary complete AV block, complete atrioventricular block during the procedure, and has then recovered. Just go over the different elements of managing, such cases. What's the duration of monitoring? How long do you keep the temporary pacemaker in? And what are the thresholds to get an electrophysiologist on board in order to help you decipher, whether this patient needs additional monitoring or is safe for discharge without a permanent pacemaker? Because I think that's a gray zone and still is evolving. And, for the listeners, Dr. Kliger and colleagues have put together an incredible algorithm in their manuscript, Figure 2. So I would recommend actually taking a picture of this algorithm or printing this algorithm and pasting it in the cardiac catheterization laboratory or in the cardiac intensive care unit, because I think it's very applicable. It's very practical, and we have the luxury from hearing directly from Dr. Kliger. So, Chad, why don't you talk to us a little bit about that?
Yeah, Ankur, it's a great question. I think, to start off, how we practice in this structural heart space is really truly multidisciplinary. We work closely with our surgeons or our imagers, but I think very true for this in particular, we really have to work closely with our EP or electrophysiological colleagues. So I think it's with their help, we're going to help come up with safe algorithms to best manage these patients. Just to start off, looking at the algorithm, we have in the past divided between a balloon expandable and self-expandable valves. as we try to simplify algorithms, we're trying to sort of merge them with data that we've done at our own local institution. But I think this gives some basic management pathway that we've utilized to help at least guide us, because I think in the past we really struggled in this space for procedural efficiency and hospital efficiency to really try to mobilize our patients and make sure that they're safe upon this approach of trying to get them out of the hospital with an early discharge. So the concept of minimalist TAVR and really looking to get patients out of the hospital at a reasonable time frame really forced us to come up with an algorithm to help really hone in how we can get patients out safely without any issues. Looking at the algorithm in the publication, if we do implant the TAVR and there's no new bundle branch block, no new first degree AV block, the device, the TVP is taken out at the end of the case. And I think that's true for most centers. I think now we're really getting these transvenous pacemakers out early, intraprocedurally, and they go to the floor with close monitoring, and all these patients do very well with these new generation devices. Patients who do develop new bundle branch block, new first degree AV block, are the ones that we really hone in on monitoring, in which case we do leave the pacemakers in, and we'll monitor these patients, and depending upon what the EKG shows and what the monitoring shows, will then dictate how we take our next steps. For balloon expandable valves, if the QRS complex, and there's good data to show with QRS complex greater than 160, there is a high risk of subsequent high degree AV block. We wind up putting pacemakers in these patients. In some cases, we do an EP study if there is a borderline, but we do take advantage, and many of these patients will receive underlying. We'll get pacemakers. We divided it in the algorithm as well to normal QRS at baseline left bundle and a right bundle branch block. Our right bundle branch block population, if they have no change in their conduction system, meaning that the QRS is unchanged, they still remain to have the right bundle. Many of these patients will leave with an event monitor for a 2-week period, and then we'll follow up in our office, and we'll get an implantable loop recorder subsequently to look long term for any risk of of a higher degree of heart block. It's important to note, and we take advantage of event monitoring because these our event monitors are real-time monitoring. That within 10 minutes of an event, our center is notified, our electrophysiologist is notified of any degree heart block, and we quickly reach out to the patient. So I think that the decision to use event monitoring over implantable loop recorders really has been focused on real-time monitoring and making sure that when we do discharge these patients, that if there are any events, we pick them up very early, and sometimes even before patients become symptomatic, get them back to our institution to try to obviate the need for events. The choice for 2 weeks, you'll see in the data in the publication, we showed some of our references show a risk of AV block out to 8 days, but the 2-week time frame I think gives a reasonable amount of time from the published data that we can pick up the highest risk patient population. Other things, if you look at the algorithm for our self-expandable valves, even though we have treated them differently in the past, now we're trying to come up with a more unified algorithm to treat all valves. QRS that is greater than 120 with the self-expandable valve, we would consider for an EP study. And depending on what the EP study showed, looking for a H to V interval that was greater than 65 milliseconds would push us to do an implant, a permanent pacemaker. In addition, this algorithm, just like in the other algorithm, we do use very heavily real-time monitoring, event monitoring, that if patients have any conduction issue change and either have an EP study or do not, that they're sent home with 2-week event monitoring for close follow-up for patients.
That's excellent. I think I would just summarize, because I gathered two really important points here, which I think maybe I think ignored by some practitioners, and that is the practice of putting an event monitor in for a couple of weeks in a patient with a baseline right bundle branch block, because it's been shown to be an independent risk for developing complete heart block in patients with transcatheter aortic valve replacement. I think is an excellent practice. And then I think you mentioned with self-expanding valves and wide QRS complexes, if they persist, doing an EP study in an HV interval of more than 65 is another excellent practice point. And then, my last question to you, Chad, is with patients at low risk going into trial for this technology, transcatheter aortic valve replacement, and I think the data will have been presented by the time we release this podcast. Where do you see conduction abnormalities playing a role if we start offering this technology, the transcatheter technology, to patients who are otherwise healthy? I mean, that's why they're at low risk for surgical aortic valve replacement. How do you see the field sort of play itself out for the low risk patients? Because I don't think any one of us would want our patients who are otherwise at low risk to land up with a permanent pacemaker.
True. So, I think a couple things. I think the patient population for low risk may be slightly different than what we've seen in the populations for inoperable high or intermediate risk, where calcium burden may be slightly different, even though it is degenerative calcific disease. Some of the features that we may take true for those prior studies may not hold true in this patient population, but that's still yet we need to understand a little bit better. I think we're learning more about imaging, so we're understanding patient anatomy. We're learning about how to measure membranous septums. From a technology standpoint, there have been changes in technology and how we're able to also implement this technology in the lab. As you and I know, we're being much better about implanting at a higher implantation depth, whether it's for core valve being in the way above 6 millimeters, shooting for 0 to 3 millimeters in terms of implantation depth for the sapien valve, where we were shooting 80-20 before, and now with the new potential ultra, now who will know what the outer skirt will do in terms of pacemaker rates with this new device, but they're implanting at 90-10. So I think the patient population may be slightly different. I think we're smarter in terms of how we implant. Technology will evolve, but I think the biggest thing is how do we understand moving forward the mechanism of what we see in these patients? Are we able to figure this out? Who are the true high-risk patients that have conduction abnormalities? How are we best able to sort of decipher who these patients are, and what are the best ways to protect them? So I think the simplest thing to do is to put a pacemaker in, even though right now we don't have data to support that putting in a pacemaker out to 2 years has any effect on mortality or outcomes. But that being said, we are dealing with now a low-risk patient population that if this becomes these two trials become positive, and if we do put in pacemakers, how will this affect these patients long term? It is definitely going to be an issue. So I think we have to grow in this space. This is definitely a space where industry is looking very heavily on, and as physicians and implanters, we have to critically think about this space as we move forward.
Great. Thanks again, Chad, for your excellent contribution to US Cardiology Review and for the podcast interview. You've summarized very well for our listeners, how we should manage patients with conduction abnormalities in the peri-TAVR period. And I think this will help clinicians out in the trenches who are taking care of these patients, better manage conduction abnormalities following transcatheter aortic valve replacement. Thank you once again for joining me and our team at US Cardiology Review for this podcast interview.
Thank you, Ankur, and thank you, your listeners, for having me. Appreciate it.
That was Chad Kliger giving us all the practical tips to manage conduction abnormalities in the peri-TAVR period. As I alluded to in the interview with him, the data on low-risk patients is literally hot off the press and has created all the buzz at the American College of Cardiology Annual Scientific Sessions 2019 in New Orleans, Louisiana. Predicting and managing conduction abnormalities following TAVR will be crucial, as it is estimated that an additional 20,000 patients will be added to the treatment pool of an existing 60,000 patients following the publication of the 2 landmark trials in low-risk aortic stenosis patients. I hope you enjoyed listening to our first podcast. I will be back with the second episode of Parallax, this time with a teacher, a colleague, and a dear friend from my alma mater, Minneapolis Heart Institute, Santiago Garcia. Santiago will teach us more about the value and the utility of high-sensitivity troponin assays in 2019. Please do not forget to rate, review, and subscribe to Parallax on different podcast platforms, including Spotify, SoundCloud, and iTunes, among others. Share with colleagues and friends on social media, and do give us your feedback. Your support means a lot to us. Thank you so much for listening.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments, and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook, and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.